Hey, hello everybody. On behalf of the PHRN, I'd like to welcome you to today's Linkage Learning webinar. My name's Felicity Flack and I'm the Senior Manager of Strategy and Services at the PHRN. I'm speaking to you today from the University of Western Australia, whose campus is situated on Noongar land. Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs and knowledge. First of all, a little bit of housekeeping. If you've got any questions for today's speaker, please type them in the Q&A box anytime during the presentation, and we'll try and answer as many questions as we can at the end of the presentation. The presentation is being recorded, and we will make it available on the PHRN YouTube channel as soon as possible after the webinar. So let's get started. I'm delighted to introduce Professor Pascal Perez, the Director of AURIN, who will give today's presentation, and also Tracy Bayliss, the Strategic Planning and Implementation Manager of AURIN, who's going to join us at question time. So the presentation today is about a joint project that several NCRIS capabilities, PHRN, AURIN and the ARDC have worked on over the last couple of years. And so we're very excited to introduce you to the Australian Urban Health Indicator project. So I'm going to hand over to Pascal.
Thank you, Felicity. I might share my screen now. Hopefully now people can see my screen.
Oh, good.
Thank you. As mentioned by Felicity, this project was a very ambitious project supported by PHRN, AURIN, and ARDC, 3 NCRIS-funded facilities. But the research work was undertaken by colleagues from QUT, RMIT, UWA as well, if not officially, but I'll mention the person, and AURIN data scientists as well. To be clear from the start, I'm here as the director of AURIN, talking about a project that was implemented by other people. And I'd like to mention the research team, the core research team, our Chen from AURIN, Flavia Barra from AURIN, Aidan Price from QUT, and Derek Lopez from UWA. There were scientific advisors, Maren Smith from PHRN, myself, Kerry Mangerson from QUT, and Melanie Davern from RMIT, and management, Tracy Bayliss, who's with us today as the general overseer and manager of the project, and Moen Mirolasani, who added more hands-on and day-to-day follow-up of the project and reporting back to ARDC and the department. So objectives of the project that started in 22. Project set out to create a series of new indicator data assets. To achieve this goal, the project proposed a holistic approach, strategically integrating various data sources, and more specifically, unit record health data from Population Health Research Network, PHRN, and more specifically, hospital admission records and other valuable data points that would be aggregated, at least initially, and specially obscured at SA1 level. So here, to be clear, all that has been done was at SA1 level to ensure patient confidentiality and smooth integration. Of course, AURIN spatial data sets ranging from access to sociodemographic information, sorry about that, employment economics, but also a lot of urban infrastructure information, buildings, roads, and so on. And finally, of course, combining these two types of information in order to get better understanding of the factors and drivers of population health according to different use cases. 3 use cases were originally thought through, and this was before I took the leadership of AURIN a year ago. The first one, led by AURIN, was the heat health vulnerability case study, which focused on impact of heat waves in cities and try to calculate a vulnerability indicator that could be replicated in any city around the country, and more importantly, try to link this vulnerability indicator with health records, as mentioned previously. So try to move, in a nutshell, from pure correlation at SA1 level between temperature indicator, for example, and aggregated health outcomes like number of casualties during a given period, into more causality links between, again, environmental factors and health consequences. The second use case led by our colleagues from QUT and the Cancer Council of Queensland, the cancer determinant case study. I won't talk about this one because AURIN was less involved in the making and the methodology of this project, but there's a report that has been produced and will be shortly available for this project. And finally, the urban livability and health case study led by RMIT. This was originally a separate component of the project from the two other ones, but due to data access difficulties, we decided halfway in the project to merge the first component led by AURIN with this one. So that's why you will see in some of the slides reference to livability index. So we try to aggregate in the same use case and the same study areas a livability approach and a human exposure to heat approach. Which brings me to the study areas. So as you can see on this map, we had 5 study areas, even if you can see only probably 4 blobs here. We had the Albury-Wodonga south. We had the Sydney, Greater Sydney area, the Illawarra-Wollongong area, just a little kind of finger pointing south, south of Sydney, and the Newcastle-Maitland area, and finally the Tweed Heads area at the border with Queensland, in order to get some kind of relatively broad spectrum of environmental, social, and climate situations. And of course, as you can see probably, each of these big regions or study areas were then refined into all the SA1s belonging to these different study areas. Why did we choose New South Wales? First, there was a mix of, first idea, if I remember correctly from what I was told, Queensland was a prime objective. Then New South Wales came into play and got the agreement from everyone for the livability and the heat island effect because of availability of data from New South Wales Health at SA1 level. Other jurisdiction had difficulties to share this information below SA2 level. So New South Wales Health at the time was the only department that were ready to consider an SA1 level. This was a relatively complex project in terms of governance due to the fact that we were accessing very sensitive data, so individual health records, linked records, which means that, as you can see on this diagram, on one side we had PHRN facilitating, coordinating the access to these data linkage units and ensuring the communication with SHREL, which is the organization that administratively look at the request, contact the primary data custodians, and then make sure that the data is put in the right data vault, which brings me to the third component here, which is the SACS Institute, who are the ones for, probably many of you on this call have used the SURE data vault before, but we had to interact with the SACS Institute, and again, thanks to PHRN, privilege links and support to the SACS Institute. So in a nutshell, what we had to do, what the researchers had to do over the duration of the project was to bring all the geospatial information from AURIN and the data linkage units from the data custodians in New South Wales, put everything in the SURE data vault and then process all this information in the vault, and then and only then extract the indicated values we needed at SA1 level. Which means that in terms of methodology, we had a 4-step process, and there's nothing new here. First, stage 1 was about data collection, catalog, and metadata generation. So, as I've just mentioned, we had AURIN has a very rich data catalog, vector data, raster data, tabulated data. Sometimes we store, many of these data sets are stored in our catalog, but others like the most recent ABS census 2021, due to the quality now of the APIs and data cubes offered by ABS, we access directly the census data from ABS. So it was a mix of internal data sets and direct access to third parties. And of course, as I mentioned, health data from New South Wales Health and the various data custodians. Then stage 2, data cleansing and pre-processing. I will take you through a couple of examples of the nuts and bolts, literally, of what it takes to get geospatial fine granularity, finely granular analysis, and how to prepare the data for it. Many people on this call, I'm sure, have had to go through several of these hoops and hurdles. And what we try to do at AURIN is to support the automation as much as we can of all these processes. Stage 3, data integration, risk analysis, and processing. This is where the SURE data vault comes in play. So we bring everything into the vault. First, there's the AURIN repository, the AURIN data repository, the PHRN, so the New South Wales Health data repository, and then everything is merged and supervised by SURE officers and the data custodians themselves. The output, as I mentioned, stage 4, we had 2 types of outputs. One, that was the one I will focus my talk about today, the Heat Health Vulnerability Index, HHVI, and the other one led by RMIT about the Urban Livability Index. So, data processing. The first big one, when you start dealing with geospatial information from a longitudinal perspective. So here we're talking various waves of census, for example, based on the SA1, SA2, SA3, SA4 nested organization as per ABS recommendations. And due to the nature of these statistical areas that have to follow the demographics of the country, well, you've got a good example here, where when you compare one SA1 in the 2016 census on the left-hand side with the SA1 that now is represented in the 21 census, you can see that this SA1 has shrunk a lot just because of the augmentation of population in this area, and several SA1s have been cut out from the 2016 one, which means that in terms of consistency and coherence from one wave to another one, there's a lot of messaging of the data in order to continue to compare apples with apples and not apples with oranges. Again, all this was automated by our team in order to have something as coherent as possible. Another example is the temperature. Of course, we're talking about heat wave. The team spent quite a lot of time trying to find which data sets would be the most relevant for the study. So remember, we were talking about SA1 levels, so that was the granular footprint we needed from a temperature perspective, and if possible, a daily time step, because some of the heat wave periods were just a couple of days, couple of weeks maximum. So the daily time step was an obvious one for us. When you look at data readily available from BOM and other providers, whether the time step or the scale works, but not the other, which means that we had to settle on the long paddock data set managed and maintained by Queensland government. that gives us a daily time step, and we can use at SA1 level. So that's the data sets we used for this study, even if it was in New South Wales. So the first thing was to clip all this information, maximum, minimum temperature per day. Then when we clipped, we processed a couple of different type of heat factor indicators, and we settled on a relatively well known and shared and accepted indicator called the excess heat factor. And then when we had that, we had for each of the areas you can see, so the 5 study areas, we could start defining periods of times and places where the excess heat factor had an obvious potential impact on population. Again, this was a lot of processing of temperature data. Another example was the building. So we have a long-standing, AURIN has a long-standing partnership with Geoscape, so we can access all the layers across the whole country at building per building level, or infrastructure asset per infrastructure asset for the ones they collect. Again, there's a lot of information to process here, knowing that we need to have something that's meaningful at SA1 level in the context of heat island effect and vulnerability of population through exposure. So we had to take building information and start plotting it as vectors on a map, and then aggregating this information at SA1 level. An easy example is the building. So number of buildings and shape of buildings and size of buildings was aggregated as an indicator, as a building density for a given SA1. So we had to process automatically all this information in order to extract building density, and the same for building height, average building height for a given SA1. Accessibility, so we're talking road and transport networks here. Again, data we access directly through our AURIN catalog. We had several points of interest in terms of access that we define in the maps. Then we use not the Euclidean distance, but road distance or rail distance from any area in an SA1 to a specific location, like a hospital, for example. Talking about effect of heat island and a heat wave on people. So how fast and how well they can access the given hospital. This was all processed and again brought together through a vector map. And then for each SA1, we had an average distance or time to a given point of interest. With all that, and I would need another hour to explain you how we calculated all that. So it's going to be a crash course here, and hopefully some of you will get the gist. So we extracted from all these different data sets a couple of indicators we thought from literature and from expert judgment were prime suspect in terms of explaining us about the vulnerability of different areas. From the environmental, urban environment kind of variables we could access, urban exposure through average roof height, as I just mentioned, building density, cool roofing in terms of color, road and path density, natural cooling, grass, canopy cover, other vegetation, so on and so forth, heat exposure, temperature deviation. So that's all the thing that was coming from the long paddock information. On the, sorry, I hope this slide is not slightly taken out at the top. So on the socio-demographic side, as you can see, we have different groupings: household composition, other sensitive indicators, socioeconomic status, existing conditions that are given by the census itself, by the ABS itself, sorry, through a different data set. So we're not talking here the individual health records, but the ABS aggregated information for a given SA1. and other risk factors, again, at SA1 level. So we mixed all that. And in order to end up with indicators we can manipulate, because for the moment we had tens and tens and tens of variables, we, the team, when I say we again, just correct me, it's the research team, went through a two-step PCA, sorry, principal component analysis method. So we had various indicators that are linked to exposure, others to its sensitivity, the third group about adaptive capacity, which is the usual now approach to a three-pronged approach to vulnerability indicators. So we took all these primary indicators and put them into a first level PCA approach, which gave us themes. So we started aggregated the primary indicators, and then the themes themselves, still grouped as exposure, sensitivity, and adaptive capacity, were put through a second PCA in order to end up with a one currency exposure subindex, sensitivity subindex, and adaptive capacity subindex, averaging all that in order to finally reach our HHVI indicator. The kind of analysis so in terms of the PCA itself, two things here. Here you can see, for example, on the left-hand side, if we talk about the urban exposure kind of sub-indicator, this gives you the main variables that contributed to the to this indicator, to this sub-indicator, sorry. And in particular, the role of roof height and building density upon this indicator compared with cool roof and road density, for example. The way it works for non-PCA specialists, so from the primary variables we put into the first level PCA, we have principal component dimensions, PC1, 2, 3, 4, knowing that PC1 gives you ideally the maximum potential, the maximum explainability of your data set, and then the PC2 gives you a bit less, and so on and so forth, where you know, beyond PC4 you don't have much more information you can extract from this new dimension. All this is based on the calculation of eigenvalues and weighting across the different variables you put into the PCA, which made us able to try to understand which, again, variables seem to pull an indicator in a direction or another. Some of these pull and push processes were quite obvious, others were quite more surprising. Which means that at the end of this process, we were able to create for each of our study areas this index breakdown with the percentiles in 2016, 2021, and being able to compare. So here you've got example for example, Sydney. We've got exposure, sensitivity, adaptive capacity, and the overall vulnerability index in 2016 and 2021. An interesting thing that the research team did as soon as we got these results was to compare, because obviously some of the sociodemographic component pulled a lot on the values of this indicator, of the vulnerability indicator, HHVI. And so we compared this with the RDS from SAFA, so you know, socioeconomic disadvantage. And there's definitely a strong correlation between HHVI we calculated, the team calculated, and the IRDS from SAFA, with some notable kind of differences, as you can see. Sorry, the vignettes are pretty small, but there's still places where we're not entirely aligned with IRSD, and it will need further investigation to understand the reasons for these differences. knowing that our data set is much richer than the SAFER data set, which mainly focuses on sociodemographic information. The relation between HHV-I and health records, up until now, it was really a nice success story. But unfortunately, it took us a very long time to get access to this data. And this hampered a lot our capability of the team to go through all the individual health records and take advantage of the richness of these data sets. We're talking millions of records over a 5 years period. You've got here a couple of variables we were able to extract. So cardiovascular disease, myocardial infarction, acute coronary syndrome, coronary heart disease, cerebrovascular disease, transient ischemic attack, heat-related conditions, heart failure. These are all primary reason of presentation to emergency services. Now, the big issue we faced when finally we got access to the data, to this data, through the Sure Data Vault and processing it, is that the number of adverse events, and here we're talking the heat wave, was relatively small from an epidemiological perspective. So it means that the first thing that the team had to do on top of processing all the things I've already mentioned is to pull data across several years in order to obtain a more statistically significant kind of grouping, which means that, you know, when you start grouping like this across years, the obvious first consequence is that you start to smooth out everything. You lose your peaks and bumps very, very quickly. So one very first consequence and conclusion we've had, not if we had to do it again, but as we continue this work and we continue to support this work, it's clear that we need to look at 10 years windows, not 5 years window for the individual health records in order to make sure we've got enough events in there to be statistically significant. So what we have so far, and it's good news, bad news. So with all the caveats I've just mentioned, what you see here is the interaction, the relationship between various indicators or variables we've pulled together and admission to emergency departments, and we're talking counts here. And again, this has been aggregated over several years in order to get some signal. If you look at the bottom row, the third graph, and so just to explain how it works. So 0 is you're during a heat wave. Regarding the year, this is a heat wave. And then you've got 2 weeks before, 2 weeks after, 4 weeks before, 4 weeks after. So we try to define this window when we might have a signal. If you're a bit optimistic, you can see that there's a little peak there. So yeah, there's a signal in terms of the response of the vulnerability index to a heat wave. But I wouldn't say that it is at this stage statistically significant. What is driving this response of the HHV-I indicator? If you look at the other graphs, you've got a couple of suspects there. Top row, you've got household composition theme, which seems to bump at the peak of the heat wave period. You've got the adaptive capacity, which is already an aggregated sub-indicator, and so on and so forth. So the frustrating part is that we've got the data, but the project funding at this stage had to end. So we had to pull the plug at one stage and give a report back to ARDC and the Department of Education. So that's as far as the team managed to go in terms of analysis. Before I go to the next steps, I'd like to mention one thing. Why did we end up rushing into the data analysis? I mentioned to you that this project was funded and started officially in January 22. The team submitted the request to SHRL to access primary data from the data custodian, so New South Wales Health. and to put this into the shared data vault. Around May, I think the first request was put in May 22. Cut a long story short, the acceptance of the request by all the data custodians and confirmation of the ethics clearance happened only in May 23. Then, and only then, the data transfer started, which means that the team itself had been waiting for a year already, and more than a year, and were able to access the data end of July 23. And then all the things I've described had to happen between literally end of July 23 and November 23. And that's for me, as a director of AURIN, the frustrating part. And I'm sure that many people on this call share the frustration because you've been through this kind of process again and again and again. I'm not saying it is bad. I think these are very sensitive data sets. But at the same time, I think we need to find a way for an authentication verification process to take weeks, couple of months, yes. More than a year, I think we can do far better in this country. And this is what AURIN and hopefully with PHRN, ARDC and other institutions, we're going to continue to push and lobby for and advocate for streamlining these processes. And again, don't get me wrong, still keeping the high level of security and safety and authentication in the process. Which brings me to the future work. Next step in the analysis, so the pilot project focused on emergency department and hospital records, requiring harmonization of diagnosis codes. This effort is in the early stages with discussion ongoing with potential partners, including health institutions and research bodies. Funding opportunities from health research foundations and government grants are being explored, including with international partners. In terms of data acquisition, future project or future phase of this project could aim at including ambulance data, which I think was pointed out by several colleagues as probably a missing opportunity in the analysis. Location-specific health event analysis, and additional data sets such as perinatal death review database and the mental health ambulatory data collection that we want to consider in the future. The use of national integrated health service information will also be explored, providing comprehensive view of health services across all Australia. Again, this is something I'm quite keen from an AURIN perspective as director to continue to work in collaboration with other NCRIS funded facilities such as PHRN and ARDC in order to push this agenda and make sure the research teams can continue their good work. Finally, and there's no surprise there, you've heard my frustration just before, we absolutely need to improve access to health data in Australia. That's a critical aspect for future work. We cannot ask our researchers in this country to come up with new models, new outcomes, new evidence if we continue to process the same way, the same data sets. We're going nowhere. So if we're serious about it, especially talking about impact of climate change on population health, we need access to these richer data sets. And again, don't get me wrong, in a very safe way. So you can count on me. I will continue to advocate. I will continue to lobby on behalf of everybody else. And I think that's probably my last slide. Thank you.
Thanks, Pascal. That was a great presentation. Now, we've got plenty of time to answer any questions that people have. So if you've got a question, you can just write that in the Q&A box, which is down the bottom of your screen. And while you're madly typing your questions, maybe I'll start with a question. A very naive question, but I wanted to know what cool roofs are. We talked about how do we work out what's a cool roof and what's a hot roof?
For the moment, it is based on color.
Okay.
So a white roof is cool, a black roof is bad.
Okay.
And I think that the government, New South Wales government, is going to start acting upon it, just forbidding contractors, builders, to continue to build individual houses with black roofs anymore.
Okay, good to know. Good to know. And I wondered whether you wanted to expand a little bit more on the sort of unique features of this approach and this project, because it has been a journey for all of us and an interesting project for us who are very accustomed to working with health data and trying to understand how to bring that together with the urban data, which is your area of expertise. And so what do you think are the real positives that this approach brings?
I think I might let Tracy explain, because she was there at the start of the process and the discussion with PHR and the researchers.
Yeah.
But what was the big exciting vision, and how we were partly drawn back to reality, but still, I'm still very optimistic for the future. So yeah, I might let Tracy answer that one.
Couldn't agree with you more, Pascal. We certainly had a vision that was bigger than what was manageable in the time frame that we had for the project, which originally was to fully automate this sort of process. We had this huge vision that we could bring the health data together with our built environment data and anything else we might care to add, and we could automate that process and make it very simple and easy. And perhaps just as that was harder than we expected, that learning is probably one of the most valuable things that came out of this project for us. So even down to the detail of we upskill members of our team to handle health data where they'd had no previous experience before. And that gives us some capacity to be able to continue similar work into the future, which we're in the process of considering at the moment.
Yeah. Okay, question from the audience. Did the researchers also explore other machine learning models for regression analysis to get the vulnerability index on top of PCA?
There was a lot of discussions about the best way, not the best way. And again, remember, we had a timing issue because we could not pre-process anything up until the point where everything was in the SURE database. That was the crux of the whole problem. So it means that when finally we were ready, more than a year later, the team had to call the shot on that one. And I remember a couple of discussions. Yeah, there could have been other approaches. PCA seemed to be the Swiss knife of the day, but with more time now, the data is in the SURE. That's a good thing. The data is there now. So it's a good point to try to other approaches. It could be a random forest approach. It can be something more sophisticated from a machine learning perspective. I'm not keen yet to try pure AI on it, but absolutely things where we think we understand what's going on when we apply the algorithm. Absolutely.
And just related to that question, the thoughts about using AI or machine learning techniques, what sort of compute do you think we'd need access to with this kind of data? Would we have sufficient with normal, or would you need HPC or supercompute access?
And that's where probably, if we're talking machine learning, so ML only with pretty well-known approaches, these approaches have been used with health data, large health data sets in the past. So I don't think we need more resources than what we could access through SURE and through our own capabilities and capacities. If you start talking about pure AI put through the test with, as I mentioned, millions and millions of records, individual records, plus the rest, and try to aggregate all this spatially, yeah, we might need to have a little bit more resources.
A little bit more grunt. Okay, fair enough.
But more importantly here, I think I'm old enough to have played with, the very, very first version of what's called AI now, genetic algorithms and neural networks. This is not a magic wand. We really need to understand what we're doing with that. And throwing AI to such complex issue, I would urge caution on that one.
Okay, another question from the audience. What are your thoughts, Pascal and Felicity, on creating synthetic data sets using this data that can be used for methods testing outside of the shore environment. I'll let you go first, Pascal.
If you remember, Felicity, and I'm not sure whether Miran is on the call, when I started to become really desperate and very, very frustrated of whether we're going to get these data sets, the individual health link records, and having played with synthetic population in the past in a different domain as a researcher, I was the one putting on the table a plan B. So, well, let's forget that. Let's get all the information we got at SA1 level. Let's create a synthetic population. Yes, I still think that good evidence is best. But again, as long as we manage to get this data much faster to the right users, and again, with all the safety nets, that's the best. But if we can't, if somebody tells us, no, sorry, it will never happen, absolutely, synthetic solutions would be the way to go.
Yeah. And I certainly wouldn't discount some of the benefits of creating a synthetic data set from this data. I think there's still questions, and it depends what you want to use it for too, and how closely related it is to the real data. So completely, let's call it mock data that is just in the same format essentially as the real data set might be helpful for training purposes or some initial algorithm development. But if you want something that actually is fairly close to the real data set, then you're still running into ethics and governance issues that would need to be worked through, and whether it could be accessed outside of a secure environment or not, I think is up for question.
And if I may add, as I mentioned, where we hit a little bit of a roadblock by the end was the fact that our heat waves are relatively short in period, which means that the number of cases on the health side are relatively limited, and we hitting the wall of statistical significance.
Yeah.
If you start putting a synthetic population, the process will be the same. So we're going to have a small period, small population. So basically, you adding a new level of error because your couple of individuals you're going to throw in the mix as a synthetic agent, you're dragging a lot of error in there. So yeah, I'd be careful. We would have probably to use a synthetic population at slightly higher in time or space level in order not to be caught into something that might be misleading.
And maybe one final question before we finish, and which might just terrify you, Pascal. You talked about the need to perhaps get 10 years of data because of the problem of lack of numbers. Would another approach to that be more locations?
Tracy, help me.
I think that we right at the start, Pascal mentioned we ran into some issues around jurisdictions for this data. Yeah. So that to me jumps out as the first problem there. It certainly is a huge barrier to adding locations.
Yes, and we should be clear that access to SA1 data requires additional approvals, and people are much more cautious about it. So that was one of the really big challenges for this project, was the access to SA1 level data. But that granularity is what provides the richness of the data. So, yeah. So I think we might finish there. So thank you so much to Pascal and Tracy for presenting on this really interesting project, and we're really hopeful that there's some more exciting results to come from the data in the future. And thank you for everybody for coming along. So thank you, and I think look out for our next linkage learning webinar, which I think is in May, which is a clinical trials one. So if that's of interest to you, look out for your PHRN newsletters and alerts. Okay.
Thank you for the invitation.
Thank you.